Good afternoon, everyone. Thank you so much for joining us today. I want to welcome you to today's training, Caring for the Healers, Part 3, Preventing Suicide in Healthcare Professionals and Staff and Navigating Postvention. My name is Rick Brown, and I'm the Associate Director of Communications and Membership with the Association of Clinicians for the Underserved, and I'll be your host for today's webinar. Thank you again so much for joining us. So I'd like to just go through a little bit of housekeeping before we begin. First, for those of you who are new to the Association of Clinicians for the Underserved, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse healthcare workforce to help transform communities to achieve health equity for all. We do that by leading advocacy, clinical, operational, and equity excellence. We provide professional education, training and technical assistance, advocacy, and more. And we invite you to learn more about us and our membership with ACU by joining us at clinicians.org. Also, I do want to mention as well that this offering is part of the Association of Clinicians for the Underserved's Suicide Safer Care program. If you're interested in more resources on suicide prevention in primary care, we also encourage you to visit our Suicide Safer Care page, where you can find a variety of resources, including toolkits and quick tips on both patient and staff suicide prevention, as well as specific populations, including pediatric suicide prevention and geriatric suicide prevention. I will put the link into the chat, but you can also scan the QR code to go directly to that page. Just to begin, I also want to go over just a few quick housekeeping items. So first, we will be recording this session. So if you need to, if you're unable to attend the entire thing, don't worry, we can send you the recording afterwards. We'll also send the slides within a week of the webinar as well. We also encourage you to ask questions via the chat during the presentation as you think of them. Virna is great at handling questions on the fly and incorporating them, and we welcome your insights and questions. Also, at the end of the session, please be sure as well to complete our evaluation. It's very helpful to help us improve our trainings. Lastly, I am honored to introduce today's speakers. Dr. Virna Little is the Chief Clinical Officer and co-founder of Concert Health. She is the co-founder of Zero Overdose, and she is an ACU Advisory Council member. We are also pleased to have with us Sarah Bernes, a consultant and behavioral health expert, and a contributor to ACU's Suicide Safer Care program. We're excited to have them presenting with us today. And with that, I will turn it over to Dr. Little to kick us off.
Well, thank you.
The presenter.
Great. And thank you for that wonderful introduction. I'm very excited to be here. And also now letting folks know, as Rick said, that we do watch the chat. One of my skills that I acquired during COVID was the ability to effectively multitask on webinars. And so please feel free to put questions in the chat or comments in the chat. We'll be watching them as we go along. And then we will, of course, leave some time at the end for some questions. So we're going to be talking today really about suicide safer care, particularly across patients and across staff. So really looking at trying to develop some systems in your organizations to really help you with a systematic approach to caring for people who may be at risk for suicide. Because one of the things we know is that suicide thoughts are not uncommon. Many people think about how they might die by suicide. Many people, have thoughts of suicide. Many people think about dying by suicide, and also many make an attempt. So really thinking about the idea of suicidal thoughts as being something more common, and really something that we should think about addressing both in the patients that we care for and across our staff. Before we really kick off today, it's always good to talk a little bit about language, because the language we use is incredibly important. You'll hear myself and Sarah say died by suicide versus committed suicide. People commit crimes, they die by suicide. So really thinking about changing that language. And I know that committed suicide is sort of a term that, has been broadly used for a long time, but really encouraging you to think about your language. Also really thinking about terms like successful or unsuccessful attempt. I often reference the time that I was introduced to a patient in a emergency room, a young woman, and they said, you know, here's so and so, she had an unsuccessful attempt. And what we're really communicating is you couldn't die by suicide successfully, or also, you know, had you been successful, you wouldn't be here. So really trying to stay away from that language. And also language around intent. So particularly oftentimes we hear language around patient, or, you know, this person is manipulative or they're attention seeking. I really try not to know someone's intent. And I know for me personally, I often find myself saying like, that wasn't my intent, right? So I don't pretend to know someone's intent. So what is really helpful is that we describe what someone actually said or what someone actually did. That's way more helpful to the other people on our team, whether it's a patient or an employee. So super helpful to really think about the language. And also what I know is that if someone is talking about suicide, they're more likely to die by suicide. So I kind of start there and thinking, really, what do we need to do next? Also really working with or caring for versus dealing with or having to deal with someone, just better language. So really encourage you to think about the language that you use both in your organization with patients and with staff. So we're going to be talking a lot about suicide safer care, both with the people we care for and also the people in our organizations. Because one of the things we know is that suicide is a growing public health problem. It is actually startling how many people we lose to suicide. And when we think about the people we care for and the number of people who die by suicide each year, and then we think about the number of providers and people who are in healthcare, you know, that we lose a physician a day to suicide, that we, you know, lose an increasing number of nursing professionals to suicide. And so really thinking about suicide as a problem to address across your entire organization, because it is a continuing growing public health problem. So why are we really focusing on health systems? I think a couple of different reasons. On the patient side, what we know is that many people who die by suicide saw their primary care provider in the month of death. We also know that people who are not engaged in care, not in, you know, dental, behavioral health, primary care, not engaged in care at all, actually resurface in primary care the month of death. So really important to know that we have a unique opportunity for identifying and caring for people who are at risk for suicide in primary care. We also know that there's been an increasingly number of healthcare providers and professionals dying by suicide, and that the numbers for individuals in the healthcare profession are actually higher. And so really making sure that we're paying attention to our patients and our team in terms of risk for suicide. We know some things about particular populations. So many of our geriatric individuals don't get the care or treatment that they need. Many of them go without behavioral health, and oftentimes, you know, many people will say, well, of course they're sad, you know, they're old. And so really making sure that we understand that people who are seniors are actually at risk for suicide. And that about a third of the older individuals don't actually get the care of treatment that they need. And about 18% of the suicides are actually older adults. And so when we think about individuals that we're caring for, and when we think about our employees and our team members or people who are retiring, as an example, as a population for being at risk for suicide. I never thought that I would use pediatric or youth and suicide in the same sentence as much as I do. It is shocking to me that 8.9% of our high school students not thought about suicide, but actually attempted suicide in the past year. You know, when they did a survey of high school students, 66% of them said they had thought about suicide. And here, 18.8% of high school students said they seriously considered attempting suicide in the past year. So certainly really encouraging you to think about the patients that you care for, the pediatric and adolescent patients that you care for, but also that you continue to educate team members, people across your organization on the risk around youth and suicide and the growing numbers, because certainly individuals on our teams have families, they're community members, and it's really important to understand that 10 to 14-year-olds, as an example, are at risk for suicide. And so it's important to ask and to understand that they're at risk. This is a pretty famous Swiss cheese slide, we call it, in sort of the area of suicide prevention, and really encouraging you to think about the holes that you might have in your organization. And so an example on the patient-facing side is that, someone might call who's at risk for suicide and cancel an appointment. That person answering the phone doesn't know that that person is at risk for suicide, doesn't know to do anything different, that they're answering or that they're canceling an appointment. So really thinking about where are people, falling through the cracks. So an example on the employee side, I know that, oftentimes, one time I worked for an organization and we had a policy around, employee and abandonment of the job, right? And that if someone didn't come in, we called it a no call, no show, for work. If that happened over the course of 3 days, that we would actually say that that person abandoned their position and would send them a note. And unfortunately, we lost a team member to suicide. And it really started to give us some thought about that policy. Like if someone doesn't come in and show, do we outreach to them? Do we have a different process or policy? Do we even consider the fact that they might actually be at risk for suicide and do something different? So really important to start to think about the places where you might have some holes in your system and where you might be able to do something different. If you haven't been to the Zero Suicide website, I really encourage you to do that. It's got some really great places to think about both caring for patients and putting some systems in place, but also thinking about team members and caring, and really just giving some thoughts about how to incorporate suicide prevention and zero suicide across your systems. It has some really nice also CME and CEU activities, so really encourage you to go there if you have not had the chance to think about it. So one of the things that we often hear on the patient side is that providers don't actually have the knowledge, to know what to do. Most people were not trained in terms of how to care for patients at risk for suicide. Most managers were not trained how to respond, or team members were not trained how to respond to someone that maybe made a suicidal statement. And so one of the things that we really encourage people to think about is actually coming up with what I call storage statements. So storage statements are something that came out of when I used to do training for social work students, and they would be doing treatment with patients and they would kind of get discombobulated. And so we came up with some generic statements that they could use to sort of help them get back on track. And so one of the things we know is that oftentimes people will make a suicidal statement or talk about suicide when we're least expecting it, and maybe we're caught off guard. And we also know, and you can probably think of times in your life when you told someone something and you maybe never said it out loud before, or you weren't sure whether or not you could tell anyone. And so that first couple of seconds after you told someone really dictated, like, do I regret saying anything? Do I keep talking? Do I tell others about this? And so it's really the same for someone who's maybe saying that they're at risk for suicide for the first time. And so whether it's a team member, an employee team member, or whether it's a patient, it's really helpful to have thought about what that response might be, and to think about generically, what do we want someone to know who just told us that they were at risk for suicide? So first, we want someone to know that we heard them, right? That we heard them say that they're thinking about suicide. So thank you for telling me that you're thinking about suicide. I heard you. We also want to let someone know that they're important to us, that we care about them. Your life is really important to me. Your life matters to us. Your life matters to us here at this organization. Your life matters to us here at this practice. And then also, we know that there's one thing that actually saves lives more than anything else, and that's giving someone hope. People who have hope often don't die by suicide. And so letting someone know, I have hope for you. I can see how strong you are. It was really strong for you to talk to me about your thoughts of suicide. And so one of the things that I encourage you to do is to actually practice maybe at a staff meeting or at a lunch when you're gathered around with some of your team members, just some storage statements, because I've had so many people, just 2 or 3 statements, because I've had so many people come back to me and say, gosh, I really didn't think of some storage statements on my own, but I was really glad that I had heard yours or remembered yours to use. So thank you for telling me you're thinking about suicide. Your life is really important to me. I have hope for you. I can see how strong you are and how much strength it took for you to tell me that you're thinking about suicide. So those storage statements are really important. I also think it's helpful to understand what puts people at risk for suicide. So we've learned a lot about suicide, and oftentimes many people who die by suicide don't have a mental illness, but have a lot of, for example, social determinants. We know that social determinants are a huge driver for being at risk for suicide. So relationship problems, financial problems, employment problems, those are all risks for suicide. And so oftentimes it's helpful to ask people. So sometimes someone who's struggling financially and having some difficulty at home like you are start to think about suicide. I'm wondering if you're thinking about suicide. So really understanding the role that those social determinants play. And that many people maybe don't have depression. Anxiety is a huge risk factor for suicide. Understanding the role of alcohol and substance use certainly play a role in being at risk for suicide. And we want to make sure that we understand transitions. Sometimes people think, well, it's just coming out of the hospital that is really putting someone at risk. But it's any transition. It's coming out of the hospital, medical or psychiatric, out of substance abuse treatment or alcohol treatment, out of foster care, out of jail or incarceration. So really understanding that those transitions or those things going on in someone's life really puts them at risk for suicide, more so than other times, and particularly in the first days, but generally within the first 30 days after those transitions. So many of you are using the PHQ-9 for screening patients, and now many of the employee assistance programs are doing it. Many are also giving it to staff. It is important to note that question 9, as many of you are familiar with, does ask about suicide, thoughts that you would be better off dead or hurting yourself in some way. We do know that someone answering positive to question 9 does actually mean that they're more likely to die by suicide. So certainly continuing to ask people about suicide is incredibly important, and understanding the positive response here. This is the adolescent version. I've actually included it because oftentimes people will ask me whether or not there is an adolescent version, and there absolutely is. There are some evidence-based tools out there for assessing risk. One of them is the ASQ. That is often commonly used in healthcare organizations, particularly for the pediatric populations. And that because it has some really nice information for nursing and for parents or guardians. However, most often used in primary care settings to assess risk, which really does happen across the board, is the Columbia scale. This is often really helpful to use with patients because it's color coded. But one of the things that we're seeing is now that if we have staff or team members who express risk for suicide and who are often seen in our practices, that it's really important to use tools as well, like the Columbia scale, so that we can actually assess risk for them and then decide an appropriate level of care. Because oftentimes when someone is identified, they may see a provider or someone on our team. So really important to follow some of the same systems and practices that you would do when we're caring for patients. And it's important to understand and ask people, what are some of the reasons you wouldn't die by suicide today? And understand protective factors, because people who have more intent and less reasons for living or protective factors are actually more at risk for suicide. So particularly from healthcare workers, we hear that their job is a reason for living. I need to be there for my patients, right? My patients are really important to me. I'm one of the only providers in this rural area. So people and families really depend on me. So oftentimes patients are actually a reason for living in many of the healthcare workers that we talk to. And it's important to think about safety planning and understand safety planning. We actually used to do something called contracting for safety. We don't do that any longer because we know that's dangerous. We do some safety planning. And I think it's important to understand some of the basic things we can do for our team members, and even to put information up on bulletin boards, or oftentimes we flash messages on computers, that we want team members to see across our organizations. So understanding that 988 is up and live now. There's actually flyers on the 988 website that you can put on bulletin boards, both in waiting rooms and in staff lounges or in places where staff are, so that people know that 988 is now up and running and available. And also information like Now Matters Now, so that they can go, there's activities there that they're able to do. So to know that that resource is available. Both Now Matters Now and 988 are evidence-based. They're available 24 hours a day. They're really good resources to put out to staff or team members to know that they're there and they're available. And also websites like Suicide is Different, so that there's information for people who maybe have loved ones in their lives, or people in their communities or in their circles who are at risk for suicide. And really giving somebody some safety planning, which is available on the Now Matters Now website, so that you could print out and give to people in order to help keep them safe or to have available. And to be able to do some safety planning and understand what safety plans are. This is actually the Stanley and Brown safety plan. It's one of the evidence-based safety plans. It can be helpful, obviously, to do for patients, but also to have available to staff or team members, because that can actually be really important to people to be able to do that. And yes, of course, we'll make this available. It's also helpful to know what means of suicide for people. So, we've had, I had a medical assistant one time who tried to die by suicide, and her means was medication. And so it was really important to talk to her upon her, return to work, and to do some planning around access to medications and what that would look like for her on the job. And so really thinking about lethal means restriction and what that looks like for both patients and for team members, and making sure that you're asking some of the questions and that you're involving partners like your pharmacy or some of the others. And really thinking about what your organizational response is going to be to suicide. Because it's important to do training on suicide safer care, both for patients and then also for team members. Oftentimes we don't train our team members, particularly our managers, on how to respond. I can't tell you, as a senior manager, I've gotten phone calls that said, we don't know what to do. One of our staff members saw someone posted a suicidal statement on Facebook and they haven't come into work. Or someone saw someone post something on social media that they were sitting in their car in the parking lot during a lunch hour, thinking about suicide. And so really training managers, how do we respond? What systems do we have in place? And then talking about it at staff meetings. I know, working in a community health center, we used to do something called this hazardous vulnerability assessment. And we used to think of all these things. What would happen if a subway car ran off the rails and went into our health center? Because we had to think of, so many things. And then I started to think, well, you know what would we do if one of our team members died by suicide? And then we actually incorporated that into our HVA, and thought about a response and did some teaching and training around it. And so thinking about what that looks like. And really making sure you include human resources, because oftentimes managers will call human resources. So is there some thought, does human resources know what to do? Do they know what to do and can respond? Is there an organizational response? If you have an employee assistance program, are they trained in suicide safer care? Have you had that conversation? And so the best response is one that is planned beforehand. I want to take a minute to just answer that question that came up in the chat around the PHQ versus the Columbia scale. And so I know that Sarah's actually answering that as well in the chat. Thank you. But actually a little bit apples and oranges. The Columbia scale is really used to assess risk. So thank you, Sarah, for answering that in the chat. So when we think about what you might want to do organizationally, one of the things we've heard is that oftentimes people don't get care or treatment for thoughts of suicide because they have some concerns, like, will this affect my job, right? Like, will this affect my ability? Oftentimes, no matter what we say, people need reassurance that it won't actually be available to employers that they've sought care for suicide risk. Oftentimes people, particularly some of our staff that may be more prone to living paycheck to paycheck, how much does behavioral health services cost? What's the availability? If I can't afford behavioral health services, what other options do I have, right? And so really answering some of those questions as part of orientation or as part of onboarding is really, really helpful. Maybe just a one pager that says, hey, we're an organization that talks about suicide. If you're at risk for suicide, here are some resources. Here are some questions about our behavioral health benefits. Here's where you can go for some help and assistance or to get some questions answered. That would actually go a long way. And so thinking about training considerations, we know that sort of one and done trainings aren't actually helpful. So we encourage you to really, steer away and really think about two populations. What are we going to do for our existing employees to let them know that we're a suicide safer care organization, that we think about suicide and suicide prevention, versus new employees? How are people coming in going to know? And really thinking about trainings being very specific. So I will say that it is not often that I learn something from Joint Commission, but I did actually learn something from them during a visit where I got a ding, actually, around our compliance training, because we were doing one broad compliance training. And really, when you think about training, it really is helpful to make it applicable to the folks that you're training. So when you think on training on suicide or suicide safer care, let it be specific. Use very specific examples when someone called human resources for the HR team, or when a billing representative had somebody make a suicidal statement, so that you're not just sort of doing a one size fits all, but you're using real scenarios for that particular group. And that you also think about suicide safer care training for patients and combining it. So oftentimes we learn how to do the EMR and then we learn how to do suicide safer care. Combine those so that you're learning them all at once. And what would it mean to really embrace suicide safer care across our organization for our team members and for our patients, and really being thoughtful about what that would look like? And thinking about training as an organizational approach. So listing all of the job titles. Sarah and I actually worked together on a project one time where we listed all of the job titles and engaged the senior leadership, and then came up for each of those categories what training was required around suicide safer care. And really thinking about engaging those senior managers so they understand why their department. So facilities, why is it important for your team to be trained? Well, because people that are in your department are at risk for suicide, but also because one time we had a suicide No, found in a garbage can. And I actually did get a phone call at 2 o'clock in the morning from a facility person that said, hey, I don't know what to do. I got this phone call, right? And how does training get reinforced across your organization? So really thinking about the suicide safer care across the system, right? What is expected by providers? What is expected by people, really creating a culture of wellness so that it spans across the entire organization. This is a place where we talk about suicide. We talk about suicide at staff meetings. We screen people for suicide. We talk about the importance of letting someone know if you're having thoughts of suicide and giving people resources. So I'm actually going to turn it over to Sarah to talk about postvention and really following up with postvention. And Sarah, I will continue to watch the chat and be your right-hand person while you take it away.
Thank you. I have several resources that I'm going to put in the chat as we go along. The first one is from the National Action Alliance for Suicide Prevention, and it's their blueprint for suicide prevention in the workplace. I know often our workplaces are a little bit different because we're both providing care and we have staff members who might be in need of care or suicide prevention, crisis intervention themselves. But I wanted to mention that the things that Virna has covered are all included in this resource. It's just organized in different ways. So they break it down into 7 or so different components of screening. Just like we screen patients, we need to have a way to screen staff. That might be optional. It might not be. If you have some sort of annual wellness or a physical, I know some fire departments, for example, that have an annual medical physical are starting to require, a depression screening using the PHQ-9 or a PTSD screening, things like that. I know I don't think we have any, fire department officials here today, but I like that example because they have thought a little more than some other types of organizations about an annual structure. So the Action Alliance resource talks about screening, talks about mental health services and resources. And really that comes down to if we have staff who need treatment, where do they go? And do our insurance offerings allow that? Does our health insurance cover mental health services? Can they get treatment? Is that from our organization? Is there a policy or a recommendation that they go outside? If you're the only game in town and they need treatment, they're gonna get it from their workplace. What does that look like? How are their medical records protected, et cetera? They also discuss suicide prevention training, which Virna discussed, different life skills and networking connectedness, crisis management policy and means restriction, education and advocacy, social marketing, and leadership. So just a resource that organizes it in a different way. I am now going to transition to talking about postvention. So postvention, sometimes folks say it's a made-up word. That's true, but all words are made up at some point. The word was coined by Ed Schneidman, who is the modern founder of suicidology, or the study of suicide prevention. So if you think about prevention is things that happen before. Intervention might be while somebody is in a suicidal crisis, and postvention is after. So you can see a definition here on the screen from a task force of the National Action Alliance. And I want to point out a couple key things. First is that it's an organized response. So kudos to all of you for being here, for really thinking about how your organization would manage this if it occurred. And it's in the aftermath of a suicide. Most often that's referring to a death by suicide, but sometimes that might be referring to a serious attempt by suicide, or a suicide attempt that was quite public, whether that's in the community or on property of your organization or workplace itself. You can see here there are 3 purposes for suicide postvention. We want to help folks heal from the grief and distress of losing someone to suicide. Whether that be a colleague or a patient. A lot of what I'm going to talk about and the frameworks here apply no matter who the person who died was and what their role was. I'm going to focus mostly on staff or employees, but you can think about or feel free to ask questions in the chat about how this might apply after a patient death as well. We want to mitigate the negative effects of exposure. We know that being exposed to death by suicide increases one's risk. So by virtue of the profession we've chosen as healers or helpers, mental health and medical professionals, we are exposed to a lot of pain and suffering, and unfortunately, in many cases, a lot of death and dying. And that increases our risk by suicide. The more exposure, the higher the risk goes. And we want to prevent suicide among people who are at high risk after an exposure. And I'll talk a little bit about who some of those groups of people might be. All right. So an overview of what we're going to talk about, I have a slide or two on each of these. This is one way to think about what you need to do after an employee dies by suicide. This is not the only framework to use, and I'm going to put a link in the chat to another framework that has 10 steps. A lot of the steps overlap. So in the chat, I just put the National Action Alliance 10 steps for dealing with the aftermath of a suicide. That's a manager's guide to suicide postvention in the workplace. So specifically for employees. High level, you want to make sure, you find out about the death somehow, lots of different ways. It might be a small town and you hear about it. It might be that person no called, no showed. Somebody called, maybe there was a well check to their residence. They were found. Maybe a fellow employee was a friend of theirs and found out or knew. Lots of different ways that your organization might find out. I would suggest you have a policy on what happens when that happens. Are folks supposed to tell HR if they find out? How's it going to get to the right leaders to make sure that the response is appropriate and quick? So verify the death. We'll talk about coordinating resources to support our staff. We want to disseminate information. Word travels fast, so does rumors, and we want to provide accurate, helpful information. We want to make sure that we're identifying who's most impacted in our organization, who was, best friends with the person who died, who worked together, who shared an office with them, who's going to be hit the hardest, so we can support them in different ways if they need something else. We'll talk about how we can commemorate the person who died. And then finally, an ongoing step is, as leaders in healthcare organizations, how do we improve the mental health and wellness of our employees overall? Really broadly, we focus often on specific, how do we prevent suicide? I will say personally, right, good policy is good suicide prevention. So increasing paid time off, increasing salary, decreasing stress, patient caseload, operational challenges that we have all the time in healthcare organizations, making people's jobs easier, making it less stress, making them, more able to do their jobs. Broadly speaking, all of those things are suicide prevention. Those are the much harder things to do than just saying, well, we're going to bring in a training or we're going to bring in therapy dogs one day, right? Longer lasting impact if we talk about work-life balance and keeping people healthy at work. So first, we need to verify the death. You need to know, who, what, where, when, and why, and if there are any other extenuating circumstances. Would hate for an organization to start planning, make some sort of announcement on the person hasn't actually died. It was, somebody else, or the person may have made an attempt and be hospitalized, maybe in the ICU, something like that. So we need to get the facts straight from the beginning. If the death occurred at work, obviously, if the person is still alive, we need to initiate life-saving services if possible. And if the person has died, contact law enforcement, call 911, make sure the scene is kept clear, and we're not exposing people unnecessarily to that scene. Your workplace probably has policies about family notification, hopefully a process for collecting emergency contact information for employees who they would want contacted if something happened at work. Law enforcement has policies for next of kin notification after a death. You might consider as an organization if a representative from the organization would go with law enforcement or make contact shortly after. Who is that person? What does that look like? Is that HR? Is that executive leadership? Is that, somebody else? A lot of this is guidance, and you really need to sit down ahead of time and think about what your organization's postvention plan is going to be. This is a roadmap for the steps. Who's going to do each of these steps? So another task that needs to be done is you need to coordinate resources. What's available for your employees to support them during this time, aside from each other? And first, what policies and procedures apply? Do you have a policy on an employee death from any cause? What does that say? Does it have specific guidance or instructions for family notification or for communication to the company or for communication to the community if the death was public or if it's a small town, or if for some reason that's appropriate given the situation, and it might be. You know, you have human resources. Do you have an employee assistance program? Do you have a partner agency that can bring in mental health professionals if someone wants to talk? And I know that's hard, as many of you are mental health professionals working in primary care settings or others. My recommendation would be, if possible, bring someone in from outside. You know, we've done it both ways in different circumstances. But I would hate if, you know, I worked in an organization and I was the one doing the support for fellow staff members. If they didn't like me, they never did, and I was the person that was assigned to help, right? That's going to prevent them, be a barrier for them to come in and get services. So some people might want to talk to a professional briefly that they've never met before. And they can have that option if you have a partnership with another local agency or crisis center or a consultant, somebody else who's a little more objective, a little bit outside, and more importantly, isn't going to be grieving and feeling the impacts of the loss themselves, so that they're a little more disconnected from it. More and more healthcare agencies are creating peer support teams, whether they're called RISE or critical incident or things like that. If you have one, you know, involve them, see what's already been done in terms of education. And then others, you know, these are some ideas. Think about in your agency, does legal need to be involved? Are there other departments, other resources that are unique to you or your community? Next, you need to disseminate information. We want to provide accurate information and timely information. When you identify the groups that need to be informed, you can also decide what level of information each group needs. So often that's an internal notification that one of our colleagues has died. You may or may not indicate that that was from suicide, depending on the family's wishes, how much information is known. If the family is not on board with calling it a suicide death, you might just call it a sudden death, or so-and-so died suddenly, something like that. I wouldn't let that stop you from providing information, because word travels and staff are going to get information from somewhere. People talk. Different shifts, you know, if it's weekend or a day where services aren't being provided, people are going to find out. You know, people call and text each other and support each other. It may be appropriate, depending on the circumstance, to provide public notification, whether that's to local media or on social media, things like that, and keeping the details pared down. In either case, both cases, you want to follow existing death notification procedures. What does that look like in your agency when something happens, whether there's a death by suicide or any other death? Very important is we want to avoid providing information about the method somebody used to kill themselves. It's not particularly helpful, even though some people might want to know. What's relevant to say is that, you know, the person died, there's resources available, and we want to support you during this time. You want to identify a media spokesperson in your organization. Hopefully that kind of position exists already. If not, designate one during a time of crisis, and make sure that they have solid talking points on mental health, suicide prevention, and wellness, and I'll show you a resource for that in a minute. And you want to provide a written statement. You know, you don't just want to have a staff meeting and talk to people. You want to provide some sort of written document that includes resources at the end. This is one example of a written statement on the right here. This is actually from a fire department after a member of theirs, employee of theirs, died by suicide, and it was public on Facebook. I thought they did a particularly nice job. We want to include factual information that who the person was, that they died, if appropriate, and if the family is on board, acknowledge that it was a suicide, express your condolences, indicate plans to provide support. So if that is, you know, a drop-in availability in conference room A, or if that's the information about the EAP program or HR or any other resources there are, provide that here. If you have information about funeral arrangements, provide that. If not, indicate that that information will be forthcoming, so that if your employees want to support or provide a comment or memorial or sign a guest book for a funeral or memorial, they can. And then if this is a public statement, you want to provide immediate contact. If it's an internal statement, I would also suggest asking staff not to speak with the media, to protect the family and make sure that the details that the family wants kept private are kept private. I'm not going to read you the statement example here, but you'll have the slides for reference. So the way that the media covers suicide can positively or negatively influence future suicidal behavior. Negatively, if we sensationalize suicide, if we somehow give the impression that it's typical, or that it's a accepted way to manage one's problems, we can see an increase in suicidal behavior over time because of that. But conversely, the Papageno effect, if the media reports well on suicide, increases resources, that help is available, doesn't sensationalize, we can encourage help seeking in the community and the audiences that media is reaching. So if you are the designated media spokesperson at an event or a time like this, go ahead and go to reportingonsuicide.org, and you can play a key role in educating the reporter, the editor that you're talking to, in reporting in such a way that will not increase risk for the public later on. All right, so you verified the details. We have figured out what our resources are. We've got a plan together to disseminate information broadly to the right audiences, no matter who, depending on who those are for our situation. We want to go through a process to identify and support the people who have been most impacted. You can see a little chart here that really we should be communicating to all employees, providing it some additional psychoeducation on common reactions, even if you feel like your employees know this already. It hits different when it's, your friend or colleague that has died versus a patient or somebody that you didn't know. So provide resources on what common reactions are after a suicide death, and refer to vetted resources. Again, cover and include information on where they can go to be supported. What does that look like if they need some additional time off, if they want to use sick time, to grieve, or let's talk about how we're going to cover shifts for staff who want to go to this funeral. Do I have to take my own sick time for that, or is the organization going to find a way for me to attend for a few hours or take that day off, or something that doesn't come out of my own sick bank, which I know is difficult in short-staffed organizations, but important to think about this ahead of time and figure out a way so that people feel supported and not like they've been betrayed by the organization. So you want to identify who this person's close colleagues were. And I think some of that's just asking around, right? Who the folks are that eat lunch together, or who go out on weekends together, or who attend the same social or religious organizations. Come up with a plan to check in individually with those people. Maybe that's somebody designated in HR or a crisis team. Maybe it's the person's manager. Different responses work differently, work well in different organizations. And then the person's family, next of kin, or designated emergency contact. I would suggest assigning a family liaison, likely someone from HR. You want to offer to pack up that person's, the deceased person's desk or office, and deliver those belongings to them. Want to make sure you do that in like a box so it looks nice, it looks a little put together, and not just a trash bag or something that's, here's all their stuff. We want to ask that family what support is going to be most useful for them, and we want to treat it like any other death. So if you send flowers when an employee dies in a motor vehicle accident, you should send flowers after an employee dies by suicide. If you plant a tree, or whatever the activities look like, they should look the same after a suicide death. The family liaison, I say, should probably be someone in HR, because if the person had a life insurance policy, if someone gets paid out at the time of death and their family gets additional benefits, or final paycheck coordination or things like that. So there's some really practical assistance here that needs to be provided to the family, and often someone from HR has the most information about how these systems work to get them benefits. All right, I started getting into this already. You want to provide ways to commemorate the person who died. You want to do it in exactly the same way you would for other deaths, so it doesn't feel like they're being treated differently, with an eye to honoring how the person lived rather than how they died. So just because they died by suicide doesn't mean that's who they were. They led a whole full life before then, and we want to honor that as well. In your planning for the future, you want to plan ahead for a year from when the person died. Mark on your calendar the anniversary of their death. Often staff will start to feel uneasy, anniversary of trauma, and not know why, or start to be a little down or depressed, just like our patients would, around key anniversaries. Other key dates might be the person's birthday, anniversary of when they started working at the organization. But think about it with your team of, what should you really put on the calendar so you can communicate out, again, even if you don't mention the person individually. The resources are available if you're feeling, these certain ways, common reactions, and where you can go if you need some assistance. And then really after a suicide death, you need to spend some time thinking about supporting employee health and wellness. What does the policy and procedure say? How does your organization currently support employees after a colleague has died? I have not talked at all about supporting patients. And that may be a topic for another time. Patients do need to be notified if their providers have died, and what that notification looks like, how that looks, will be organization specific. What do employees say they need? Not just what we as leaders or managers think they want, but let's come up with some way to survey them or do focus groups or involve a committee of sorts to figure out what our employees want in their own words. And then what can we do overall to increase employee mental health and wellness? A handful of additional resources that I wanted to mention. A couple of them I have slides and a couple I'll put in the chat. One is the Suicide Prevention Resource Center. They're funded by the Substance Abuse and Mental Health Services Administration to advance the national strategy for suicide prevention. This page that I linked you to here, sprc.org/states. Every state in the nation has a state suicide prevention coordinator and a state suicide prevention plan document. So if you go to this website, you can find the one from your state. If you're not connected to them already, I suggest you are. Just reach out, introduce yourself and say you're interested in suicide prevention, whether it's a certain group or patient population, your employees. They often know where the grant dollars are or have programs that include training that your organization might be able to take advantage of. Another resource I want you to be aware of is that every VA medical center and many of the VA freestanding clinics have a suicide prevention coordinator. These folks are great. They know a lot about postvention. If you're looking for gun locks to distribute internally or to patients at fairs, resources, business cards that have the National Suicide Prevention 988 crisis line number on them, all sorts of things like that. They can be a great resource as well. So if you go to that website with the Veterans Crisis Line, you can search by zip code and then you can filter by type of resource. And in this case, you'd want to look for suicide prevention coordinators. It'll come up. Again, I recommend you introduce yourself to these folks ahead of time, develop the relationship, and collaborate where you can. I just put another resource in the chat that's from the Veterans Administration. It's from the Rocky Mountain MIRIC, which is the portion of the VA based out of Colorado that deals with suicide and suicide prevention. They have fantastic resources on suicide postvention, whether that's employees who have died by suicide or whether it's supporting employees after they lose a patient to suicide. So I just put that in the chat. I highly recommend you take a look there. There's so many great resources there that we don't have time to cover today. So with that, those are the end of my slides. Rick, if you want to come back on, if you're there, and you can help us moderate. If there are questions, please go ahead and type them in the chat. I don't know if I missed any.
Thank you so much, Sarah. That was fabulous. And so we wanted to make sure to leave about 5 minutes at the end for any questions or comments. There were a couple of folks who did ask about whether or not there were going to be the slides available, and Rick did announce in the beginning that he will both share the slides and any resources. So just reminding folks.
I think it's also worth mentioning that when a patient dies by suicide, you can follow similar steps. Think about a process for informing, staff, the people who are providing care to that patient. But depending on what kind of patient they were, what services they were receiving, like if they were in group therapy, for example, maybe they were attending a smoking cessation group or a men's depression group that you were providing, is it appropriate to notify the other patient members of that group or not? I know it gets sticky. There's legal issues there. I'm not going to provide an opinion one way or another because you need to consult with legal and your clinical leaders to really see, what information can and should be shared there. That's going to be helpful. But there's a lot to unpack with postvention, whether it's an employee that dies, whether it's a patient that dies, or whether it's a high-profile other person in the community who's died by suicide.
Wonderful.
Feel free to put any questions in the chat.
Oh, and Sarah, Virna, I'm actually seeing a question. Are there any, obviously not giving identifying details, but are there any examples from your own practice of times that you've had to implement either postvention or you've seen organizations take good steps in terms of prevention?
Yeah, I would say, I did a webinar last year with a large community health center group in New York that lost a nurse practitioner to suicide. And it was interesting to hear them talk about that they really hadn't prepared to really think about what they would do if they lost someone to suicide. And I think I would really encourage, some of the advice today and some of what Sarah talked about, really thinking about what a response would look like, writing it down, doing some additional training and having some thought sessions, in advance so that you're not trying to figure some of these things out, when your organization and some of your team members are in crisis.
Yeah, I'll second that. The organizations that end up doing postvention the best are the ones that have thought about what they will do ahead of time. Whether that's a table talk exercise, you think about, I remember when Verna and I worked together and we had bomb drills, right? Different safety drills, fire drills. And I got to be the person who called in the fake bomb threat to one of our clinics, which was super fun for me. But you might think about planning some sort of drill like that for managers or leaders of what would this look like? What would the steps be? And developing a policy or procedure around that. You can get feedback ahead of time if you draft, a sample notification. And the manager's guide for suicide prevention in the workplace does have that, a couple templates there that you can use as guides. And you could ask a few key staff ahead of time. If a fellow colleague of ours died by suicide and this is the email or notification that got sent out, does it have everything you'd want? Are there words in it that you wouldn't like?
Yeah. And what needs to happen and who's going to do it?
Yeah, absolutely.
So,
yeah, I see a comment in the chat.
Yeah, can be a sign person.
We didn't really cover specific warning signs for, employees that might need assistance. That's a great point. A lot of good things put in the chat there.
Isolation, and we actually did a webinar with a health center, and they had someone who had been isolating, they knew was having some relationship problems, actually gave some of her belongings away, work belongings away. And so when they were really, doing some postvention activities and really learning and being able to put some systems in place to be able to identify and support.
I see another comment that I'll read out loud. This person saying, I asked my supervisor at work if there's support for our own doctors where I worked, and my supervisor said he tried to get a staff therapist from outside, but it wasn't materialized. So it got me thinking if I should go to HR elsewhere. He asked if I was concerned about a doctor, and I said, no, I was just curious. Yeah, I think when we think about healing the healers, a lot of times we forget or haven't really considered what support is needed. And the regular employee health and wellness type programs that might work in other types of work settings don't often work for these folks. They have a much higher base knowledge of, risk factors, warning signs, mental health, things like that in some cases. And in some cases, they also have more knowledge of and access to lethal means, whether that's medication or just knowledge of what would be required to end a life. And that's a unique warning sign in itself. Whether that's you going to HR or if there's a wellness committee, I mean, I don't know what your role or position is. I think it's a great place to start.
Mm-hmm. Well, great. I want to thank everyone. Rick, I'll let you close it out, but it's been a pleasure to be with everyone today, and thank you for all of the great questions.
Yes, absolutely. And thank you so much, Virna and Sarah, for such an engaging conversation. I just want to end with saying that if you have any follow-up questions, we are happy to try to answer them. You can email either myself or Virna, and we'll make sure to follow up with contact information as well. There are also further resources for suicide prevention on our website at clinicians.org as well. Thank you all again for attending, and I hope you have a wonderful day.
Thank you.
Thank you.